Good evening, everyone. My name's David. Welcome to another of ACPP's webinars and the continual set of PD opportunities that we'll be offering our members and the wider paramedic community. Well, before we begin, I'd like to acknowledge the traditional custodians of the lands where my Australian-based colleagues are located and pay my respects to their elders past, present and emerging, for they hold the memories, traditions, culture and hopes of Aboriginal and Torres Strait Islander people. In recognition that we are a binational college, I take this opportunity to acknowledge the Maori as Tangata Whanoa and the Treaty of Waitangi partners in Aotearoa, New Zealand. This evening, I have the pleasure of reintroducing my long-term friend, Dr. Lauren Shearer, who is one of Queensland Children's Hospital's consultant paediatric cardiologists. Dr. Lauren has over a decade working in a variety of paediatric and adult congenital cardiology roles across Australia and the UK, and she is passionate about integrating frontline paediatric cardiology knowledge across all healthcare professionals. Dr. Lauren has a particular interest in early cardiac illness investigation and diagnosis, paediatric palliative care, and child to adult transitional care. Dr. Lauren will be joining us again later this year to discuss her other interests relating to paediatric care. However, today she will be discussing nuanced paediatric palliative care and the interdisciplinary approach to these complex patients and their families. I'd also like to acknowledge that while this topic is very important, especially to healthcare workers who are involved in the care of children, I'd like to highlight that this topic is sensitive and can promote strong emotions. If anyone here who's choosing to join us is feeling as though they need to seek care, I'd encourage you to go through your local pathways and find if you find any of this content distressing. At the end of the presentation, for all of our people here who are joining us live, if you have any questions, please feel free to pop them into the comment section and I'll go through them in the order that they appear. Without any further delay, I'd like to pass on the webinar to Dr. Lauren.
Thank you, David, for the introduction. So my name's Lauren Shearer. Just to start off, I also would like to acknowledge particularly the Turrbal and Jagera people, the traditional custodians of the land on which I'm presenting from. The land and rivers of Meanjin and Brisbane have been a meeting place for thousands of years, and I'm privileged to be here today. I also wish to acknowledge the traditional custodians of the land on which each of you are living, learning and working from today. As we share teaching and knowledge today, may I pay respect to their elders past, present and emerging. I particularly welcome any Aboriginal, Torres Strait Islander and other First Nations peoples joining us. And like David, I wish to acknowledge the patients, family and friends of patients with life-threatening illnesses, the journeys they travel on and the challenges they face in the lifelong progress of bereavement. Some may not wish to view this talk as it may remind them of personal and shared experiences, provoke strong emotional responses and revisit feelings of grief and trauma. If you are feeling distressed, please talk to your support network and remember that help is available. And I remind you of Lifeline Australia and New Zealand, the Mental Health Triage Service in Australia and Samaritans in New Zealand. As a disclaimer, I have no financial conflicts of interest to declare. Some of this work was prepared as part of my work with Queensland Health, but is presented in an individual capacity and is not policy or otherwise representative of Queensland Health. Some of this work was also prepared as my part of my clinical diploma in palliative medicine, and my position was supported by QOCA, the Quality of Care Collaborative Australia. And I also want to highlight that I'm not a specialist in paediatric palliative care. So I'm a paediatric cardiologist. I've worked through most of the east coast of Australia and also in London. As part of my training, I have become somewhat of a specialist, and I want to acknowledge that once you become somewhat specialised in any particular field, it can be difficult to have perspective of what those outside the fields will do. So please forgive me if I end up a little bit in depth in things, and we can ask some questions at the end. And today I mostly want to talk about work that I use in my everyday practice and informed by my training through the Clinical Diploma of Paediatric Palliative Medicine. And we can talk a little bit about that. But again, I'm not a specialist in paediatric palliative care. I do want to visit as we start some key definitions. And palliative care is different from end-of-life care, although one is encapsulated in the other. Palliative care is an approach that improves the quality of life of patients, their carers and family members facing problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification, impeccable assessment and treatment of pain and other problems, physical, psychosocial and spiritual. End-of-life care is really care needed for people who are likely to die in the next 12 months due to progressive, advanced or incurable illness, frailty and old age. Many experience rapid changes and fluctuation in their condition and require support from health services, family and carers. Paediatric palliative care is particularly worth mentioning and particularly confronting because children are not expected to die. The diagnosis of a life-threatening disease in childhood is often unexpected and can be very hard to accept. Childhood survival in developed nations is increasing, and so many people will never be exposed to a child they know dying during childhood. In Australia, the infant death rate, so that's children below 12 months of age, is about 3 per 1,000 life born, and that's halved in the 2 decades from about 1999. Primarily, this is perinatal complications, but also congenital and other acquired diseases, including SIDS. The early childhood rate is about 3.7 per 1,000 total life born. So from 1 to 14 years of age, it's only 0.1 to 0.12 per 1,000. Again, that nearly halved in the decade from 98 to 2011, although it's been fairly stable since then. And this compares worldwide to an infant death rate of about 6.5 in Europe, but nearly 50 per 1,000 births in Africa, and a childhood death rate in Africa that's nearly tenfold that in Europe. And apart from, so in contrast to adult palliative at end-of-life care, the nature of illness that causes death in childhood is quite different. Clearly, injuries represent one of the largest portions, but also we see a much smaller group of all cancer diagnoses. So acquired conditions, respiratory, circulatory and congenital abnormalities all represent a significant portion of children who die. And in palliative care, more than half the children receiving paediatric palliative care will have non-cancer diagnosis, as opposed to the significant majority of adult palliative care. And so therefore, although paediatric palliative care shares a philosophy of care with the adult specialty, of holistic and multidisciplinary care, of maximising supports through home and the community, and of collaborative practice, paediatric palliative care has developed a distinct model of delivering care that is generally consultative, with ongoing cares being provided under the home teams. It's in parallel with treatment to cure and often much longer duration. Parental desire for resuscitation does not preclude involvement of palliative care, and we focus on delivering the right care for their needs at the right time in the right place. Care can even begin before birth, perinatally, and include counselling and bereavement of parents before the birth of a child antenatally diagnosed with serious illness. And so we can categorise these various conditions into various frameworks. This is one. And at the top of the list, we've got the life-threatening conditions for which curative treatment might be feasible but can fail. And so this is, for instance, cancer where treatment has already failed once. For instance, relapsed cancers, things like stage 4 neuroblastoma, but also patients with end organ dysfunction where transplant may or may not be an option. The second category is life-limiting conditions where premature death is inevitable, but there might be long periods of intensive treatment aimed at prolonging life and allowing participation in normal activities. So things in this category might include HIV, complex cardiac disease, some of the muscular diseases like Duchenne muscular dystrophy, and one that's been in this category more significantly previously is cystic fibrosis, where with intensive treatments available in the modern era, life expectancy is now significantly increased out far, so that most of them can expect to live into their 40s. The third category is the life-limiting and progressive conditions, so without curative treatment options. So this might include things like the neurodegenerative conditions, metabolic conditions, and neuromuscular conditions. So treatment here is exclusively palliative, but may extend over many years. And then there's another category of illnesses where the disease itself might be irreversible but non-progressive, but still be life-limiting, causing severe disability and susceptibility to health complications and likelihood of premature death. An example of this is severe cerebral palsy or patients with multiple disabilities who might be prone to complications such as severe recurrent pneumonias or intractable seizures, where the cerebral palsy or disability itself is not the cause of death, but leads to significant healthcare needs, significant psychosocial needs, and a significant likelihood of early death. And the kinds of conditions we deal with are quite extensive. In oncology, clearly there's the things like brain tumours and relapsed leukemias, particularly those who've already had bone marrow transplant, things like stage 4 neuroblastoma or progressive solid tumours despite primary courses of treatment. Certain congenital and genetic disorders might be important, things like trisomy 13 or 18, particularly when there's multiple other disabilities associated with that. Asphyxiating thoracic dystrophy, the Potter syndrome, and other rare genetic disorders. Neurological conditions include progressive neuromuscular conditions such as Duchenne's or spinal muscular atrophy, the neurodegenerative conditions, leukodystrophies, severe acquired brain injuries and hypoxic ischemic injuries from neonatal life, intractable seizures, things like the brain reduction disorders, anencephaly and migration disorders. On the metabolic side of things, we have things like the complex mucopolysaccharidoses, Krabbe's, Niemann-Pick's, Tay-Sachs, and other mitochondrial disorders. From the cardiac side of things, the complex single ventricle patients, pulmonary atresia, particularly with hyperplastic lung arteries, but others such as severe Epstein's and severe pulmonary hypertension, which may not be associated with congenital heart disease. Gastroenterology might include shortcut syndrome, often a complication of neonatal and premature complications, liver failure, particularly where transplant might not be an option or may have failed. Respiratory includes things like cystic fibrosis, but mostly those who've had early disease progression and are already being considered for lung transplant. There are dermatological conditions such as epidermolysis bullosa and renal conditions such as some children with end-stage kidney disease, particularly where there's been a failure of renal replacement therapy. And so revisiting those definitions, what we're trying to do here is prevent and relieve suffering by means of and identification of pain and other problems, including physical, psychosocial and spiritual. And this lies in the paediatric sphere very much in parallel with care with intention to treat. Care with intention to cure generally begins at diagnosis and it will follow a varying course. There may be periods of high and low intensity, and high intensity often brings more symptoms as a consequence of treatment. But the aim is to treat the cause, causing relief of symptoms, but treating that cause causes symptoms. And at the end of that treatment with intention to cure, a patient may end up cured, although could have residual disease or side effects, or may be unable to be cured. Now, palliative care, care with intention to relieve symptoms, should also probably begin at diagnosis because it does not exclude treatment with intention to cure. And it also follows a varying course. There will be periods of high and low intensity treatment for symptoms. High intensity treatment of palliative care should bring relief from those symptoms. But importantly, we know that treating symptoms can benefit treatment of the cause. If you are able to tolerate the side effects and symptoms of your treatment, we are usually able to complete standard and evidence-based treatment more effectively. And it's important to also say that symptoms may outlast the cause, both symptoms of the underlying disease or symptoms of the treatment. An example may be that if you've had a limb amputation from a solid tumour, even if that tumour is completely resolved and you have no relapse, you've still had an amputation. So you still need care for symptoms from the underlying treatment. And so there is this bow tie model between disease management and intention with cure to palliative care. And there is an overlap between the pain and symptom management of both of these modes of care. Survivorship and rehabilitation may extend beyond treatment of the underlying disease, and palliative care and hospice care, including end-of-life care, may extend beyond treatment of with intention to cure, or may overlap even towards the end. So paediatric palliative care certainly has a couple of domains. And in terms of symptom management, it's important to get history and assessment of those symptoms, identify causes if possible, implement therapy, but also regularly reviewing and modification of treatment and progression. And an example would be if you have pain, then making sure that you've done appropriate investigations to work out where that's coming from, and directed therapy may be more effective and actually is part of that symptom management. So assessments need to be age and family appropriate. So that includes things like using age appropriate pain scales, the FLAC or visual acuity scale, and interventions might include non-medication interventions, medical treatment, surgical and procedural interventions, but also consideration of how to deliver that care, whether that be enteral, parenteral, or by a clinician or by the patient and family. And certainly we feel that there is benefit involving patients and family in that symptom management. Empowerment is a core tenet, and this includes generating respect for the family, respect that each family is unique in its makeup, its values, its relationship, and its history. They all have their own strengths and weaknesses. And it's important to acknowledge that the death of a child is beyond a parent's control. So families facing illness or death feel an enormous loss of power. They face navigation of an often institute-focused model of care, and they lose control of care options, freedoms, and relationships. They may be transported significantly out of their location, particularly if they come from a regional or rural background. They may be focused towards a tertiary centre and might even have to move interstate to receive the care for their child, breaking down some of their usual support structures that they usually rely on. And it's important to also say that children generally share their parents' values. So we do adopt a parents knows best attitude. And what I really mean there is that we assume that we assume that parents very much have their child's interest at heart, and the children would share their interpretation of instance. So we support parents in their advocacy, in their access, and we assist them with the family needs, not just our own as clinicians. Communication. So in terms of that, we need to look at the right place of care. And again, a little bit different to some of the adult palliative care philosophy, that care is not universally at home. Although many of our patients will receive a lot of care at home or periods of lower intensity care at home, complex planning may be required to allow back transfer of these patients. Hospice care is available, but quite limited for children. It's only available in some states and territories and may provide practical support and home-like environment for the patient and family, but they can also support the rest of the family. And a lot of the models is not necessarily long-term inpatient at hospices, but targeted therapy and programs to help adjustment, assessment, and treatment of palliative care symptoms. Death in hospital is quite common in children, and families may prefer either a local or a tertiary centre, and providing transport and care responsibly is important to allow them to have some control at the end of life. And certainly many children will die within an intensive care environment. That may be in a paediatric intensive care or a neonatal intensive care, and means that we need to have a compassionate understanding of needs, limitations of treatment, and access to treatment. And some of these patients will have such complex symptom management that the only way to effectively deliver that relief is through an intensive care environment. Intensive treatments, both the cure and symptom management, may require that intensive care, and certainly some parents will require full care and maximally delivered care in an intensive care environment to be able to feel that everything has been done to their child. Communicating with the family is very important. We have to have active listening, listening what the family have to say, but also thinking about how they communicate, looking for their emotional and other unsaid messages. And sometimes it's what they don't say that we need to listen most for. The influences affecting their position, their perception of the situation, and also their understanding of the situation. If we are to empower them to make informed decisions, we have to be able to assess and ensure that they have adequate understanding. We want to give information in an open and honest manner. We want to give them adequate time, preparation and support, and we need to be able to check that understanding. So we need to practice that active listening even after we share information. And special consideration needs to be made for those who are culturally and linguistically diverse, who may need more specific and culturally appropriate checking of understanding, as well as culturally appropriate education. And we also need to communicate with the children. What do we tell the children is one of the most common and biggest question that families have when involving palliative care. It's important to say that we actually need to listen to the children first. Adults do tend to tell their children things rather than listening to them. So we have to practice that active listening and show respect to the child. We need to understand where they are, where their understanding is, and their understanding of the world around them. And we need to use that to build trust in the relationship with the patient. Children's understanding of death is complex, and although informed by development, it does tend to defy clear division into the different stages of development. But in general, we find that most children understand death from an age of about 7 years as a universal, irreversible, having a number of causes and relates to non-functionality. They do tend to understand that people who have died are unable to continue to do things. And the illness affects children as well. It disrupts their life. It disrupts their ability to do their usual routines and activities. It changes what they can do, and they might have associated disability. In some children, it will significantly change their appearance over time and certainly disrupt things like schooling, friendships, family, and relationships. And we often face the burden of parents wanting to spare the child. But actually what we often find is children likewise want to spare the parents of their distress. And we certainly have patients who've talked to me who'll actually tell me, don't tell mum and dad, but I don't think they know that I'm dying. And so they do show that insight even from quite an early age, particularly if they've had a long relationship with healthcare. We follow general communication rules, but we do have to tailor it to the family. We have open discussion with parents regarding what will be discussed with the child and when. We try and answer the children's questions that they have, and not always just what they say, but the questions below their understanding. We try and communicate in a way that they engage in. We share their language, we share their formats, and that may include play, storytelling, and sharing videos and TikToks as well in the modern era. And where possible, we answer honestly and appropriately. We try not to overwhelm with details, but we have to be aware that the children often have feelings of blame and guilt, and we have to reassure them at every stage that it's not their fault and it's not necessarily anything to blame. Where possible, we often have to repeat information, and that repeating of information is not necessarily a lack of understanding, but a normal communication for strategies for children, seeking a reinforcement and connection with the message, and being available, understanding, and practice that active listening is very important. In terms of coordination, we have to be playing a role between coordinating many teams. The child and family is at the centre of this. And extending out from that, we might have to engage with schools, social workers, friends in the community, nurses, general practitioners and local paediatricians, as well as paediatric specialists and specialist liaison nurses. In palliative care, we can act as a bridge between a tertiary centre and a regional centre, including the Paediatric Palliative Care team and specialist teams and the allied health professionals that come with those tertiary centres, while also mobilising support organisations, allied professionals and children wards closer to the patient's home. And importantly, we provide that spiritual and community support because children will have friends, families, schools, who will all be going through a process here that will often benefit from targeted communication and coordination. Bereavement continues to be care, and the loss of a child is a lifelong grief. But the bereavement almost starts at diagnosis, because grief is a cluster of thoughts, emotions, behaviours and experiences that are related to a loss, and that includes anticipatory grief. When we talk to parents with children with a life-limiting disability or diagnosis, they will often early start feeling a loss of the expectations for what they wanted their child or hope their child would achieve. And they see their children suffering and see this growing difference between what they hoped and wanted for their child and what they see ahead. And they feel this grief as an impending and expected loss, even when things are stable. And there's a broad range of normal and adaptive responses to grief. Some of our families will have a deep and existential emotional reaction, and this can be deeply distressing and difficult for us to understand and observe. Some of our families, conversely, may be very emotionally suppressed and avoid discussion of things that distress them as a way to cope and get from day to day through the process of having such a life-limiting diagnosis. And our role is not to try and make them go through any particular stages or process, but to support them. So we support the patients and the family through the grief process. We try and facilitate their understanding of the reality of loss and enable their exploration of feelings in the way that they need. We try to help them overcome and adjust to the change environment, and we assist in the identification and the pursuit of their quality of life. But as I said, the loss of a child has a profound and lifelong impact on a family, and we're there to be accessible, to be able to share information with them. But it's important to acknowledge that they are the ones going through this journey, and it's not fair to expect us to be able to push them through or expect them to go through any process other than their own. It's us to be there to support them, but unfortunately they are the ones that will go through the grief process. So when it comes to practical considerations, we can talk about what kind of tools exist to assist in the caring for these patients and families. What kind of symptoms might they be facing? And where can I access additional training and resources? And one of the most important tools generally used in paediatric palliative care and palliative care in general is a symptom management plan. And this is an example of one of my patients. And this can be used by multiple care teams, and it may be used to identify possible symptoms, interventions, and escalation options. It should identify key contacts in the care team and who should be contacted after hours. And these tools are generally written with the family in mind, and the family will be an important part of delivering these cares. And this example includes things like non-medication techniques for pain, breathing difficulty, vomiting and feeding issues, constipation, which is a big issue in paediatrics, sleep and irritability, often a significant concern for family members, and temperature instability. And going through various steps with this provides a tool both for the family to work through, and if we are in the community with them or responding to them, then we can access this, which is usually with the family or available through a medical record. Other correspondence might be available. So some of this might be with the patient, such as seatbelt exemption letters or previous letters from specialist and palliative care physicians. They might have discharge summaries from a hospital and hospice, which will generally have some summary of the condition and treatments. There might be specific documentation available through ambulance networks, although a weakness of this is it's often tied to a specific location or mobile number. But the better ones of these will have a specific care plan. This is a different one of my patients, well, actually has a suggested list of medications for a variety of complications the child might have. They might be available through information technology resources, such as the Viewer in Queensland, or the My Health record in Australia if they've been posted to that and there is access. But there's also often hotlines set up, and these might be in or out of hours hotlines. And for instance, in Queensland, the Paediatric Palliative Care Service has a 24-hour service for known patients, where you'll be able to talk to a palliative care clinician who should be able to access some of that information and guide you through the symptom management plan and how to assist the family. More general resources is available, and the Oxford Handbook of Paediatric Palliative Care is quite useful, but I'd like to highlight this work, which is a practical guide to palliative care in paediatrics. This was initially made a number of years ago through the Royal Children's Hospital in Brisbane and has been updated since. And this, I'll refer a little bit to this when we go through some of the symptoms and management plans. But you'll also find many institutional and organisational guidelines in the approach to palliative and symptom management care. When we're talking about the symptoms faced in paediatric palliative care, they do vary significant with the underlying process, prior treatment and prior complications. Pain is especially common with neuromuscular and cancer diagnosis, and shortness of breath is particularly common with cardiac diagnoses. Irritability, sleep disturbance and other neurological symptoms are common across all of these, but may be a particular feature of the neurodegenerative disorders. And feeding difficulties with reduced intake or gastrointestinal symptoms such as nausea, constipation, vomiting and diarrhea may present in a variety of features. And certainly one of the most powerful things that parents feel is the need to provide nutrition and care to their children. And when they have reduced intake or difficulty feeding, that can actually be quite distressing for parents. In terms of pain, it's important that we assess them appropriately. So tools like the FLAC or the FACES pain scales, colours and numbers are not quite as good for those at younger ages, but might be appropriate for adolescents or young adults. The causes should be assessed, and cancer-related pain may be very similar to those in adults, but non-cancer pain is often multifactorial, including both musculoskeletal changes and dystonia, as well as other injuries. Management is often through the key principles of by the mouth, by the clock and by the ladder. So we often will focus in paediatric palliative care on oral or buccal routes. It tends to be simple, convenient, safe and effective. We try and use regular scheduled intake rather than PRN dosing, as it reduces peaks and trough and generally gets better control of pain. And a stepwise approach progressing through multimodal pain relief, including non-medication, non-opiate and opiate medications. There are many myths about pain in children, and we actually do feel that infants and children do feel pain just as much as adults. Although opiate tolerance can be observed, addiction is much less so. And patient and parent controlled analgesia is important for empowerment, efficacy, but also safety. Many people will be concerned that opiate treatment of children in pain reduces life expectancy. But if anything, actually the evidence is to the contrary. An increased tolerance of pain, increased treatment of pain will increase quality of life and tolerance of treatment, both with intention to cure and of other symptoms. Gastrointestinal symptoms, including nausea and vomiting, are quite common, and they might be directly due to disease, they might be a consequence of treatments, and they might be a consequence of constipation. Particular direct triggering of the chemoreceptor zone, such as by medications or the vomiting centre through mass effect and central nervous system lesions. Metabolic diseases may also affect that. Visceral transmitted signals and raised ICP directly affect on the vomiting centre, but also mechanical obstruction or gastrointestinal inflammation will contribute to nausea and vomiting. And so we have to identify contributing causes, target therapy to these causes, and try and combine non-pharmacological and pharmacological measures. Non-pharmacological things include things like ginger, but also sipping water or ice chips, or using bland or salty foods to reduce the central activation. You might need direct agents such as ondansetron, metoclopramide and pyrazine, and often a combination of these will be required. And indirect agents may be helpful. Certainly anxiety can be a driver of nausea, but also things like proton pump inhibitors or other motility agents, or aperients if there's constipation. Breathlessness is quite common, particularly towards the end of life, but may be a presenting feature of some syndromes. It can be intermittent and reversible, but it might reflect deterioration in underlying status. There can be respiratory causes such as active infection or difficulties with oxygen transport, but also non-respiratory causes such as metabolic acidosis, systemic infection, fluid accumulation, and muscle weaknesses and chest weakness. So we identify early the resuscitation and escalation status. We correct easily reversible causes, and we relieve the symptoms as much as able within that escalation framework. Certainly we should be trialling positioning and oxygen if that's tolerated, but not all patients will tolerate oxygen delivery. And certainly non-invasive and invasive ventilation can worsen symptoms. We should try and relieve anxiety, including things like breathing and relaxation exercises, a quiet environment, and increasing air movement through the area the patient is. Some patients will have significant secretions and difficulty clearing them, so careful secretion suction may be indicated. Opiates are an important part in the treatment of breathlessness, and they moderate the reflexive drive to breathe and decrease the awareness of dyspnea. It's important to know that the dose we use is significantly smaller than that used to control pain. It's often about a third the dose required for pain management, and it's not associated with reduced longevity. So opiate treatment for breathlessness is not bringing about the end faster. We have to overcome some of those perceptions, but it's very much directed at reducing the symptom of breathlessness and actually tends to give them more effective breathing and can actually prolong life. Irritability, anxiety, and sleep disturbance are also a common presenting feature. Assessment, it's important to know this will be quite distressing for patients and carers, and we need to look for central causes and psychological causes, as well as both reversible and irreversible causes. It may be very appropriate to be distressed, and particularly anxiety about symptoms that are ongoing or upcoming. Pain should be addressed carefully and evaluated. That might be both somatic pain, but also neuropathic pain with a wide distribution of causes. Central neurological system changes may accompany deterioration or be an effect of a primary lesion and may affect patients' arousal, awareness, and conscious state, but may also contribute directly to pain and other symptoms. So again, using non-pharmacological strategies, having a calm environment and reasonable routine, reducing stimulation, and using senses that remain intact if they've been impaired. And that might be touch and voice, particularly if there's vision impairment, use of senses and storytelling and this sort of thing is important. Anxiolytic therapy may be a part of treatment, and occasionally we'll use gabapentin or midazolam as part of a treatment plan. Very occasionally, and particularly with psychiatric assessment, we might need psychotropic medication. So if we want to look at further training in palliative medicine, on the medical side of things, there'll be people with a clinical diploma in palliative medicine, and that's aiming to extend the expertise of general practitioners and physicians to handle palliative care needs of patients in their core practice. And it's not equivalent to specialising in palliative care, but it is a 6-month full-time and accredited position, as well as additional course work and assessment. In contrast to this, there's advanced training in palliative medicine, and this is what a specialist in palliative care will do. This is post-basic physician training or acquiring a specialisation in another specialty such as general practice. It's generally 2 to 3 years of core and non-core training, and it provides fellowship either in the College of Physicians or the Australian chapter of palliative medicine, and entitles you to register as a specialist palliative medicine physician. For those in the allied health, including paramedics, there are generic resources that you can use to facilitate continuing professional development, such as the PALCare training, the Palliative Care Online Training Portal, the education modules at the End of Life Essentials, and also pcc4u.org.au. And most of those will have links to other resources that may be available to you. But then there are formal resources and courses. There are graduate certificates in palliative care through the Australian College of Nursing, and also the graduate certificate and diploma in palliative care, such as the Charles Sturt University and Flinders University, and in the more adult-focused palliative medicine, the aged care certificates and diplomas will also address palliative medicine. And there is an opportunity there to progress to a master's degree in palliative medicine for allied health practitioners, specifically for paramedics in advanced practice. So rounding things out, in conclusion, paediatric palliative care is a holistic and multidisciplinary care process tailored to the needs of patients and their families. It can extend from diagnosis through symptom relief, through the bow tie model of overlapping treatment for cure and treatment for symptom relief, and extends to cultural bereavement and community care beyond the death of a child. Resources are available for individualised care, but also further learning experience, and provides opportunity for meaningful care to a highly deserving cohort of patients. And although this field can be very distressing as a care provider, it can also be incredibly rewarding and can be incorporated even into the most invasive of allopathic care. And as a physician whose practice involves quite significant interventions to children with complex congenital heart disease, I do try and include some of these palliative care modes of care from the get-go, so that we are addressing that holistic care of our patients, even as we pursue care with intention to cure or significantly prolong life. I'd like to acknowledge some of the resources that I've used today, and then I'd like to open up for any questions that people might have.
Thanks, Dr. Lauren. Another fantastic presentation, and I think a really important one. I think pediatric advanced illness and especially children who are linked with palliative care services is a really tough area for all clinicians to engage with. And I think the take homes for me at least is really understanding that these patients have got a team around them, and being able to integrate with their team and make calls where possible if you have any questions, and understand where the support networks and systems are in that place. It's really important. I might just start off with some questions, and anyone live at the moment, feel free to pop them into the comments box. I wanted to touch base, Doctor, on what could be done, or what is your experience in supporting families with Indigenous backgrounds and the complexity of perhaps providing palliative care for children in more remote settings, or in situations where the family have been wanted to be more connected to their remote country? We obviously have a significant Indigenous population, and their geographical locations can certainly be challenging. And I was wondering what services were available, or what considerations, particularly with that social and psychological modes of care and considerations are for Indigenous people.
Absolutely, and an excellent and important question. So patients of Indigenous and First Nation background often face significant barriers in access to care in the first place, and might be displaced significantly from their culture and lands to access care with intention to cure. So palliative care often needs to involve early involvement of resources such as Indigenous liaison officers, community resources such as Indigenous health services. And my experience is often one of the challenges is having access to health literacy, health access in a culturally sensitive way, and finding that balance between care with intention to cure, which may need to be delivered in a tertiary and very distant from traditional lands manner, and care with address to symptoms, including that psychological, spiritual and social distress. Certainly the palliative care practitioner has a role in advocating for appropriate community care, return to country where appropriate, And when we're providing that, addressing the differences in methods of communication, in methods of advocacy, and who will be contributing to decision making needs to be very flexible and culturally informed. I might just pull up an example from the Northern Territory. This is a Northern Territory Aboriginal palliative care module. And again, it still includes that patient and family at the centre, but also acknowledges that extra layer of kinship, culture and country. And that informs things like values and belief and traditional practices and language, but also the history, the mothers and fathers' country, and the different roles and responsibilities that they'll have. And around that, we have extra things to make sure that we're getting the right story and the right people involved early, which may not conform to a very Western or allopathic method of delivering care. And so we need to be flexible and have that cultural awareness, but also be informed by the experts in delivering that cultural care. And unfortunately, institutional care is often much less flexible in this than we really should be. And particularly when we're very subspecialised and very rare diagnoses, it can make it very difficult and confronting for these patients and their families, particularly around the roles of men and women who they may not have access to that in the hospital environment. I think return to country is very important, and grief processes are very important. And again, being informed of that and educating yourself in the right ways in general, but also allowing yourself to be informed by the family and having that central role of them in the care is critically important. Again, we're not the ones who have to walk through this process. They are. So our role is to help them navigate, advocate, and work their way through that process.
Yeah, navigation, advocacy, really critically important, and particularly when it comes to families.
And I think designing care structures is important, and trying to support those who may come from a First Nations background, who may not have those traditional qualifications to be involved in that care, both delivering palliative care in the community, but also other healthcare. So those Aboriginal healthcare workers, as an example, of people that we need to be reaching out to and trying to connect, because really often the resources can be made available because these are very deserving but also very poorly delivered care for these patients. So we need to focus on them to increase the care and quality and deliver it in the way that they want, and they can help design that care.
Sure. We have a question, Dr. Lauren. So the question, I guess, is split into two parts. It's how do you think paramedics and paramedic practitioners can integrate into the wider paediatric palliative care team? And the reason why I say it's split into two, I'd probably go and consider that, you know, when we're talking about paramedic attending a patient in the setting of an acute response in an ambulance, the 000 call has been made, we've responded out, versus a paramedic practitioner who might be part of a primary healthcare team in a rural setting or otherwise, who knows and has known this patient for some time. So what are your thoughts on what paramedics can do now in both of those settings, and what would you like to see into the future with paramedics and your patients?
Absolutely. So I think the first thing to do is access and acknowledge your local resources. So things like these online resources are quite useful to go through so that you can inform yourself about some of the considerations there. Now, if you are in an ambulance situation responding to an event, accessing the symptom management plan, but also having the patient and the family at that focus. We do not expect or ask necessarily families to acknowledge a not-for-resuscitation order to access palliative care. And many of our families will need to go through quite intensive care to feel that they have done everything for their child. And it's not up to us to limit them where it's non-futile. Of course, there may be resource limitations, but we need to understand that these are plans and the family's needs come first. So listening to what they're telling you, listening to what they're asking for, and assessing the patient and delivering the care that you can. Contacting their specialists, generally that palliative care team, if they've been involved, or their treating specialist, is absolutely appropriate. And most of these specialists will be aware of their patients, or they'll have somebody covering them even overnight to be able to give you advice. And so escalating that care if you're uncertain is appropriate. Being aware that particularly in many jurisdictions, it is okay for children to die at home if they've got, particularly if they've got an expected illness, and being aware of what the local frameworks, including legal frameworks and notification required, has been. We certainly face with families who feel that they need to call the police, or that might be a barrier to death at home. And that's not necessarily the case in all jurisdictions, particularly when a local general practitioner or palliative care physician is involved. In the community, being aware of the way to assess these symptoms, the variety of symptoms and treatments that might be available, and getting those resources from your tertiary care teams is important. Acting as a local coordinator will be important going forward. And in the advanced care space, I think there's an important role for these sort of care navigation officers who can provide a link to the community, can provide that next level of care beyond just community care, and help them navigate and advocate through that combination of both treatment for intention to cure and treatment for intention to relieve symptoms. So trying to facilitate the delivery of this bow tie model in the community, I think, is important. You don't need to be a doctor to deliver good palliative care. You don't need to be a nurse to deliver good palliative care, but you do need to educate yourself and build those communication and strategies with the family and patient and put them first. And you can do that regardless of where you're responding. And you can communicate with your the family there. We do hold that parents have the best interest of their children, and children share the values of their parents.
Maybe just one more question, Dr. Lauren, and I think it links in really closely to what we've just been talking about with parents and best intentions for their children. You did mention earlier that some patients may not have been told by their parents that they're dying, and parents will have various reasons for making that decision. In these circumstances, how does your team approach this issue? And how do you advocate for your patient in a setting where the family may not want them to know the diagnosis or part of the diagnosis or the process going forward? It's probably a very complicated question, I understand that, but yeah, I think we'd be interested to know.
It's certainly a very important question, and that can be very confronting for clinical staff involved in these cares. But what I want to highlight is the framework we use for care in children is that you still need to have consent to provide care. And for children, the consent giver is the parent, unless there's other legal frameworks placed in place. So the assumption is that that parent is consenting for the child. You cannot deliver care that you do not have consent for. That said, it is a journey, and it's a journey that those parents and those patients are on. So it's our job to help support them and understand. We don't need to agree with their decisions, but we do need to help them be informed about the challenges of that approach. And certainly we often find that in those sort of situations, the children know that something's wrong. And we have to advocate for the children to the parents to say they'll know that something's wrong. And if they don't get given the information in an appropriate way, they will feel that guilt and that they will feel that they are responsible. And it goes both ways. We definitely have children asking us not to tell their parents that they're going to die, particularly in that situation. That's absolutely something I've been told by a child. Please don't tell my parents, I don't think they know I'm dying. And that's heartbreaking, but it's also important to acknowledge that that's the values of the children and parents, and we need to have that forefront in our mind in delivering that care. I think a tangent to that is the overlap with the concept of the mature minor. often shortcut it to Gillick competency. And there'll certainly be a spectrum of competency here that may change at different times. And the threshold for discussion is obviously different in a 16-year-old who's living somewhat independently and informed in their choices, and a 2 or 3-year-old. But of course, the communication needs to, as far as possible, be open and honest, and you can say what you're not allowed to say or your parents have been asked not to say. So you do have a role to inform, but it's not your job to override the parents. The parents are the ones generally providing consent.
Yeah, thank you for that. Another question from the group here is, how has COVID-19 affected the delivery of care to your paediatric palliative care patients and their families?
So COVID-19 certainly has brought changes in healthcare throughout and access to healthcare. We've had significant difficulties with cross-border care and access from regions into central areas. Remembering that my primary practice is in cardiology, so I've not been at the forefront of delivering paediatric palliative care through the pandemic. But when we've always tried to have that right care, right delivery approach, the use of telehealth continues to be important and something that we should all be advocating through our governments to continue to provide access to. And that's again where that community paramedic might be able to facilitate, so that rather than travelling all the way into the city or travelling to a centre that might be associated with previous painful procedures, memories and different family grief process, getting them care locally is important. We do have a small number of children who've had severe illness from COVID, but we've also had a lot of patients with complex disease who've had limited access to hospital because of restrictions and travel restrictions as well. And that has posed a challenge. But I probably would have to defer to those specialists in palliative care. They're the ones who've been at the coalface and doing that. Certainly, they've still continued to do a great job and had that very patient and family-focused delivery of care.
Yes, no, absolutely. It's been really amazing watching the telehealth services expand over COVID-19. I think healthcare professionals across the board would agree that we'd like to see that continued and expanded wherever possible as well. It's certainly convenient for patients and does enable faster contacts for their healthcare professionals and services as well. So I fully agree. I think we might bring the webinar to a close there. Dr. Lauren, thank you so much for speaking to us today. And I do want to reiterate, as we said at the very beginning, we have covered some sensitive topics here, and some of our viewers may have had lived experience with this as well. And if anyone is feeling as though they're struggling today, to please go and contact any of your local services that can provide emotional support. In Australia and New Zealand, we've got Lifeline and mental health triage services as well. Please reach out if you need any help or support. Thank you, Dr. Lauren, for participating again today. It's just fantastic to have you on board with this very important topic. Thank you so much.
No, it's my pleasure.
Have a good evening, everybody. No.